I'm Sam Baker-Evens. I'm a nurse practitioner, family nurse practitioner, and I'm the associate medical director for substance use disorders at Esperanza, which I think is a funny title because really I'm against substance use. So not. So we're going to talk about opioid epidemic. Do you guys mind telling me, like, what? I know you're students, and that's all I know. What kind of students are you? I generally healthcare students, but just yeah. Tell me briefly what kind of what levels of are you studying and where? Yeah. Go ahead.
Undergrad nursing training.
Okay.
Yeah, I'm undergrad pre-dental.
Cool. What are you guys?
Second year medical student at PCM.
At PCM? Cool.
Undergrad
I'm good. Pre-med.
second year med student at Jefferson.
Okay. Cool. Nice.
Me too.
Wow. You guys signed up to do more over the summer because don't you get like 2 weeks break or something? This is it. All right.
Nursing.
Nursing. Cool. Nursing student currently?
I'm going to be
Cool.
undergrad pre-med.
You guys?
Undergrad pre-med.
Pre-med?
I'm undergrad nutrition.
Nice. Good. That's wonderful. So I'm going to talk a little bit about the opioid epidemic. I know you guys were out and walking around, and now you've been sitting for a while. So if you need to stand up, then I won't be offended. So I wanted to start with this scripture from Luke, which is, I consider we have a couple in our addiction treatment program at Esperanza. We have a couple kind of core scriptures. The one you see most often, you'll see our flyer around, is the Jeremiah 29:11, for I know the plans I have for you, declares the Lord. That's the one that we say to patients, I think, most often when they're in a place of not believing that they can heal. But for me, this is the verse that's core to me. And so I want to read it, and then I'll tell you a little bit of how I ended up working in addiction. One day while he was teaching, Pharisees and teachers of the law were sitting nearby. They'd come from every village of Galilee and Judea and from Jerusalem, and the power of the Lord was with him to heal. Just then some men came carrying a paralyzed man on a bed. They were trying to bring him in and lay him before Jesus, but finding no way to bring him in because of the crowd, they went up on the roof and let him down with his bed through the tiles into the middle of the crowd in front of Jesus. When he saw their faith, he said, "Friends, your sins are forgiven you." Then the scribes and the Pharisees began to question, "Who is this who is speaking blasphemies? Who can forgive sins but God alone?" When Jesus perceived their questioning, he answered them, "Why do you raise such questions in your hearts? Which is easier to say, 'Your sins are forgiven you,' or to say, 'Stand up and walk'? But so that you may know that the Son of Man has authority on earth to forgive sins," he said to the one who was paralyzed, "I say to you, stand up and take your bed and go to your home." Immediately he stood up before him, took what he had been lying on, and went to his home, glorifying God. Amazement seized all of them, and they glorified God and were filled with awe, saying, "We have seen strange things today." There's so much in this story that I think we can draw on, and when we're thinking about addiction and when we're thinking about our own lives or ministry in general. For me, when I was 19, I went to be a missionary in San Francisco with a group called Interchange, and it was actually a friend of mine from college, and I started a group that was reaching out to homeless youth on the street of San Francisco, kids who were like teenagers through early 20s who were addicted to either alcohol or heroin and were part of a subculture called gutter punks. And we ended up starting a team that's actually, they're still there. They make pancakes in the park. But I was, grew up in the suburbs. I was a youth group kid. I never went to a party with an illegal drug or even alcohol. That was just not what my friends were doing. And then I went to a Christian college where people don't even swear. And all of a sudden I found myself with these kids who, a lot of them had come out of foster care or run away from group homes, and at that time there was kind of a funnel of starting with things like ecstasy and marijuana, and then eventually they ended up in San Francisco using heroin. And and so I was completely new to addiction. I hadn't really had any firsthand experience of that, and I was sitting with kids who were shooting up. They were IV drug users, and it was in fact the same for my friend. And it was a deep dive into this world, and many days felt really inadequate. We were doing street outreach, and we were later joined by a man who'd been homeless for 23 of his 35 years. He'd also come out of a foster care situation, which was pretty bad. I'm still friends with him. And he and other folks who were homeless started to kind of teach us about how things on the street worked, and we started to learn about addiction from working with these kids who were already addicted to heroin. And I think part of the, like, when you jump into the deep end or find yourself in the deep end trying to follow Jesus into places you never expected to go, one thing that I commend to you is to hold tight to the gospel and just really look at how Jesus loved people around him. And I think out of a level of desperation, I think I clung to particularly the gospel of Luke for whatever reason, closer than I've ever done at any other point in my life, because I really needed day to day to know how Jesus loved people and how we should posture ourselves in this kind of setting of addiction and desperation and day-to-day survival. And this verse in particular, what hits me, I think, still with this verse is the group of friends who were carrying the paralyzed man, and it says when Jesus saw their faith, that he honored that. And I think all of us are going to experience times in our lives when we're the paralyzed person, and then hopefully this summer and in general in your ministry life, you're going to be the friends of the paralytic, and hopefully have a team with you that's going to help you carry people who are paralyzed to see Jesus, because the primary goal is for them to see, to experience Jesus, right? And the other thing that strikes me from this story is that the way was blocked, and I think that's really true, that the traditional ways of experiencing Jesus through the church is blocked for a lot of the people that we are coming in contact with, and particularly for people who are living in addiction. And we need to be people who tear up the roof tiles and find really unusual ways of getting people before Jesus. So I want that to kind of be the background for talking about something that's a little bit grim in Philadelphia, and that is the opioid epidemic. Did you guys see kind of evidence of the opioid epidemic walking around? And you probably see it K&A. We are surrounded by needles and folks who are using daily. Do you mind advancing? So I'll talk a little bit about the opioid epidemic. So I think you guys are probably aware of it nationally. That in the 80s and 90s, there was a big push by pharmaceutical companies to prescribe these synthetic opioids, particularly oxycodone, and to see them as non-addictive in the face of a lot of evidence. And there was a lot of, we started calling pain the fifth vital sign, and that we should treat pain at all costs. And this addictive behavior that you're seeing from patients, that's pseudo-addiction, it's not real addiction. And a lot of those, so there have been some very high-profile lawsuits against those companies of late. But what happened was vulnerable communities, particularly poor inner-city communities and rural Appalachian communities, were flooded with opioids, and particularly oxycodone. And then when we kind of cottoned on that this was happening, as medical providers, we tried to take everybody off of them, and very quickly there sprang up a market for street heroin, really. And then just to keep that all kind of complicated, we've had the war in Afghanistan, which was our main source for heroin for a lot of years, so we turned from heroin, which is an opium poppy derivative, to synthetic opioids, and there was the development of highly potent synthetic opioids. And in Philly now, really since 2017, we do not have heroin on the streets. You'll hear people talk about heroin. In Spanish, they'll talk about manteca. But but it's fentanyl. Fentanyl, or fentanyl, we hear a lot of fentanyl analog, is highly potent synthetic opioids, and we'll talk about those in a minute. So in fact, my stats are now old because we've just gotten the post-pandemic. Just like in the last couple of weeks, we've got all the post-pandemic things. We've had about a 30% increase. Each year, the pandemic had about a 15% increase in opioids. So the problem with the highly synthetic opioids is that there's massive overdose potential. So our zip code for the KNA site is 19134, and then we're next to 19124. And in the city, that's kind of the center of the opioid epidemic. It's actually worse in rural Pennsylvania, but it's very visible at Kensington and Allegheny. And these are in fact our zip codes. For Esperanza, the highest overdose rates in the cities are. Is that a smart? I didn't have that. Okay, I won't touch it again.
Okay, sorry. It's a smart.
And so we started seeing fentanyl on the street taking over heroin in around about 2014. By 2017, that was it for heroin. It's almost all fentanyl now. And so our cases of HIV, our cases of hepatitis C in particular, and overdose have all spiked as a result of that. So here's and I think I did update the most recent was that we had a 30% increase in overdose deaths during the pandemic. And so there it is on the graph. This would be us. This is our neighborhood.
Wow, it's the only one that's blue.
It's the only one that's blue. Yeah. I think the scary thing with the pandemic is, I mean, you'll see how visible it is in these neighborhoods, but the scary thing in the pandemic was everybody was isolated, so overdoses, if nobody sees you overdose, you're much less likely to survive, so that was the scary thing. And a lot of the programs shut down, or they went remote, and a lot of our patients didn't have the ability to go remote, so people in recovery were completely without support, and saw a lot of relapse. We actually went remote, and earlier than other groups went back in person because it was, because we started to see the relapses and people really struggling. So here we have drugs that cause unintentional overdose, and you can see this massive increase from about when fentanyl hits the market. This is fentanyl here, and then other types. And then here you can see our heroin supply is falling off. The weird thing is, other cities, like when folks come up from Baltimore, Baltimore, which is not very far away, doesn't seem to have fentanyl right now for what folks who are using are telling me, and they still have heroin. So why? I mean, there's like a reputation for the 95 corridor, but it doesn't seem to be consistent. And then at CCHF, I was talking with a physician who's doing addiction medicine in Texas, and they haven't seen any fentanyl, and you think coming across the border. So it seems to be very regional, but for us it's completely fentanyl. So highly potent synthetic opioids, which for us is fentanyl. High risk of overdose, they withdrawal, because we're very concerned with them getting people off of it, withdrawal starts sooner, lasts longer, and is more severe. And the reason for that is that fentanyl is lipophilic, so your body stores it in the fat cells. Heroin is not. So heroin will be out of your system, or other opioids will be out of your system in roughly about 8 hours, but fentanyl can hang on for weeks. So that makes it much higher. And then the people's tolerance is extremely high as well. So to match, if you're going to bring someone off of it slowly with a safer drug, it's much harder to get, you have to give an extremely high dose of that drug to match the level of fentanyl that they're used to. Yeah, higher CNS penetration because of that lipophilic thing, and, yep. So in Philly, it's primarily fentanyl, and then the fentanyl is adulterated with, our primary adulterant right now is a medication called xylazine that people will call horse trank. It showed up first in the environment. Great. It's a clonidine analog, so for anyone studying that type of stuff, it's alpha adrenergic agonist. In any event, it's it acts like clonidine, which will be relevant in a minute when we talk about reversing overdose, and it also causes a lot more cutaneous infections. So we're seeing, not that we weren't seeing a lot before, but yeah, when people inject it and they miss, or even if they just inject it, it'll cause abscesses and localized lymphedema and all sorts of things.
So does it bring the blood pressure down locally?
Yeah.
Okay, like vasoconstriction?
Yeah, like vasoconstricts with central vasodilation, like clonidine.
Mm-hmm.
So their pulse does not help with the whole pulse. Their pulse and their respiratory rate drop. Particularly their pulse. And how they come out of it when you reverse the opiate, you're not reversing the xylazine, which is what we'll talk about in a minute. And then other opiates that we see on the street: oxycodone, codeine, heroin, morphine, methadone. Particularly since methadone is controlled and people are dosed daily at particular methadone sites, but since the pandemic they've been giving people more take home, and with a higher relapse rate, we're seeing more methadone on the street, which we're never used to see. And but all of these are frequently mixed with the fentanyl, which is also contributing to the overdose. We also, I think, have a hidden benzo epidemic. I think we're not, because it's a little bit more prescribed and socially acceptable, I think we're not even aware of the extent to which our patients are struggling with benzo addictions. So at Esperanza, we've actually started, we are primarily opioid use disorder, treating opioid use disorder, but we've actually started to treat primary benzo use disorder as well. And then the stimulants that we see, most of the street, are primarily cocaine and methamphetamines. It's just kind of come into the city in the last year or two, and PCP. P2, I think maybe you could say that's a stimulant. Nobody can really agree on what it is, but for people, they call it bath salts or synthetic marijuana. And then you will hear when you're walking down the street, people will call out subs. They're offering you buprenorphine. And then people also sell, if you hear people offer you loosies, they're offering you cigarettes, single cigarettes, so loose cigarettes. And then marijuana, also is frequently tainted with fentanyl or well, really with anything, but meth and PCP as well. People are frequently surprised to find out what's in their urine, and we have reason to check. And at a point, because marijuana is pretty widely used, a point of education for folks is that if they are going to use marijuana, which a lot of people do self-treat psychiatric disorders with marijuana, to encourage them to get marijuana.
And get a prescription.
Which is just harmonization at that point, no matter how you feel about marijuana. Yeah.
So, like, how do you know which drugs are not on the streets anymore? Like methadone, you said, is within the last year or two. Do you just ask people?
Yeah, that's a good question. Go to the next slide. Oh wait, no, maybe I took it out. Oddly enough, Department of Public Health in Philly, somebody's job every 6 months is to do a street census. So my assumption is they go out and buy things and then test them, which I think must be the weirdest job ever. So the Department of Public Health primarily is who tells us. Yeah, and I think it was before the pandemic that they said to us, you will not see heroin anymore. It is that we are done, it is all fentanyl. And so our MAP program, which we'll talk about in a minute, tests urine weekly and always when they come in, because we need to case, but they have opioid use disorder, and it's fentanyl. We don't, I can think of maybe twice. I remember being surprised when I saw heroin in someone's urine in the last year. It was because they come from another city. Yeah. So I think it's helpful for me. Did anyone have any? That was the great part of the presentation. Anybody? We're going to get to the more hopeful part in a minute. I've found it useful in the last 25 years of working in addiction to kind of understand the characteristics of addiction, and because I think when you're close to someone who's, we all struggle with addictions of various types. When you're struggling with someone, when you're with someone who's struggling with substance abuse, it's very difficult to understand sometimes some of the things that they're doing and the ways that they rationalize and why they keep relapsing and relapsing.
Yeah, why don't they just get better?
Why don't they just
Why
get
can't they
better?
just pull
And
it together?
how can they not care about their child and go for the drug instead? It's hard to understand the decisions they're making. And so this is from a book called Grace and Addiction, which is an older book now, or maybe it's Addiction of Grace. It's Addiction of Grace. And by a psychologist, and this is his characteristics of addiction. So I think most of us are aware of, and usually if you look at like DSM-5, they'll talk about something being addictive if you have tolerance and withdrawal. So those first two are kind of our traditional definitions. If you have constant need for more and more of something, whether it is say coffee or heroin, that's tolerance, right? And to get the same effect, you need more of it. And then if when you stop it, you have a stress reaction followed by the opposite symptoms that the drug gave you. So for me, with caffeine, I use caffeine to treat headaches. If I stop my coffee suddenly, then I get a rebound headache. And indefinitely, my team notices my stress. So that's the withdrawal, and the withdrawal symptoms are almost always the opposite of what the drug did to you. So for a sedating drug like an opiate, they're going to feel more anxious and sleepless. And self-deception, the exquisite inventiveness that our minds can demonstrate, that we can deny, we can rationalize, we can blame it on someone else. And a lot of times when I'm meeting with folks who are not in recovery and I know they're using and they know they're using, but we're not being on it, like in that conversation, that's not something that they're willing to admit yet. It's helpful for me to remember that they're lying as much to themselves as they are to me. Your brain can do two things at once, and it can be aware that you're in trouble and also be in denial that you're in trouble. And then the loss of willpower. Another kind of hopeful statistic. So most people will recover if they don't die from their addiction, but most people actually do recover at some point and are able to stop using. But it takes, on average, 9 to 11 serious attempts to quit before you're able to quit for good. So sometimes when you're working with someone and they are doing well and then they relapse, I find it helpful to remember, like, maybe that was one more serious attempt on their road to finally being free of this stuff. And then distortion of attention, or the distortion of ultimate concern, which is and I think this is the part that cuts to the core of who we are as beloved children of God. Addiction will make you betray your family, yourself, ignore all other things rather than, because it focuses all your attention on that drug and getting that drug. And so many of the destructive behaviors that we see around addiction, and so much, for me, the part of their behavior that's so hard to understand, like how could they deny their child this in order to get their heroin, comes down to this distortion of attention, that they literally cannot pay attention to anything other than that drug when they are in that addictive craving state. Questions about that? Does anyone else resonate with your experience with any of those characteristics? Or So, what's the response? So here are the 12-step groups. This is the 12 steps from Alcoholics Anonymous. I think might be Alcoholics Anonymous. They're slightly different. That's Alcoholics Anonymous. So a group of Christians quite a long time ago. I want to say the 30s, but I might be there.
What, Bill W, is that who?
Yeah.
50s.
50s? Okay, there
Yeah,
you go.
my addictions professor, I had an addictions professor in medical school
Yeah,
in the
why is
80s.
that?
I know,
Yeah.
that's amazing.
And you
He
yeah.
knew Bill, he knew Bill.
You knew it. That is cool. Yeah, so a group of Christians got together in the 50s and formed what is now called Alcoholics Anonymous, or people will call themselves mutual support groups. There's Narcotics Anonymous, there's Al-Anon, which is for families who are dealing with addiction. We've got family members dealing with addiction, Narcotics Anonymous. In Australia, there's a group called GROW, which is 12 Steps for Mental Health. The 12-step community is quite a large one, and they garner a lot, and I'm sure you will hear lectures that are like, they garner strong opinions one way or another. People are either for them or against them. I think that they are one of the most evangelistic things I've ever come across, because the whole purpose of the 12 steps is to reconcile the person struggling with addiction, reconciles to themselves, to God, in their relationships with other people. That's the point of the 12 steps. And so I draw a lot of strength and encouragement from seeing recovery with a large R, as a holistic process of restoration of a lot of areas of our lives. And so you can, I won't read the 12 steps now, but you can see that a lot of it is speaking against that denial, admitting that we're powerless, that our lives are unmanageable. It's a very extremely, this is part that sometimes Christians sorry. I won't. It starts with a very gentle view of God, and sometimes Christians get affronted that it talks about a higher power and not God. But you have to remember that if your view of God is damaged, then sometimes that means restoration too. And so this is a very gentle introduction to God. And you can see there's a lot of elements of confession and kind of reckoning with what we've done in the course of our addiction, and then the 12th step is carrying the message to other people. So that's the missional step, and people move through these steps. Mm-hmm.
So are there like a lot of people that don't do Alcoholics Anonymous or something like that because they don't want to like admit to like God existing or something like that because it's okay?
Yeah, and Alcoholics Anonymous so they have another book called Red Book, and Grow, it's called Brown Book. Like the 12-step groups usually have like collections of sayings or articles that other people have found helpful that they offer, and a lot of them speak to like what if you're upset with the God language in 12-step groups. So there is a lot of discussion in that, and I believe that there are like atheist 12-step groups.
Okay.
And they do a lot of discussion about, and this is also where Christians can get upset about this, is they'll say your higher power when you're just brand new in addiction is something that you can rely on. And if the only thing you can rely on is that the number 30 bus shows up every day, and that's the only thing that you can trust in, I don't know if that's folks clearly, but then that's your higher power. Something that is reliable, that is outside of you. And they use sponsors, and for some people that is their start to believing that there's a power outside of themselves. And so that's why I see it as a very gentle introduction to relationship with God. Yeah, it's fairly overt though. They're not subtle. So at Esperanza, we'll go to the next one. We have treatment for opioid primarily, and we're just recently starting treatment for primary benzo use addiction. Frequently they're coming in with both. As I mentioned before, our theme verse is Jeremiah 29:11. We combine, so our goal is to be holistic in our view of recovery. We use group therapy and individual therapy. Our goal is to see the person within. So part of that loss of willpower and the denial thing is that it's kind of a strike on the iron top thing. So our goal is to see people the same day that they contact us, and if not within 48 hours. We use medication assisted treatment, which I'll talk about in a minute. We do intensive care management, and we have a partnership with some lawyers who will help kind of rearrange, help them sort through. So when you're newly in recovery and that whole distortion of attention, your attention is no longer on using every day and the things you need to do to be able to use that substance every day, then all the other pieces of life kind of come at you. And so restoration can look like dealing with criminal charges and warrants that you left behind, or reconciliation with family, and or sometimes not reconciliation with family, and restoring relationships with the court system, or with drug diversion programs. So we have lawyers that help with that, and case managers who help with that, and then we have a dental partnership. Because also folks need dental care, and have usually neglected that for many years. And dentistry is kind of a vulnerable time for folks who are in recovery, because it almost always needs a narcotic to block. And so sometimes that means taking them off of their medication, putting them back on it. Usually we try to avoid that. So we have a dental program that does, I don't know the dentist, but they do a particular type of blocking. These are folks with hyperalgesia and high tolerance for narcotics, so getting a complete block to be able to do their dental work is a challenge. So Asya, our amazing dentist, is our person who does that. So we do some expedited scheduling with our dentists for these folks. And then we, actually just in the last couple of weeks, so we do medication-assisted treatment during pregnancy as well. And just in the last couple of weeks, the city's homeless mobile outreach teams reached out to us and said, we're delivering babies on the street, because that distortion of attention thing again, and sometimes women are pretty advanced in their labor before they're ready to pay attention to that pregnancy. And would you guys be willing to allow us to engage women with like a walk-in prenatal care program? So that's our newest program, as I'm pretty sure Faith just signed us up to.
I was going to say, I hadn't heard of it.
Yeah, no, you haven't, because that was last week. Faith Melinda pretty much signed herself up to be like the on-call GYN for homeless mobile outreach in Philadelphia, and I'm really hoping that women in labor don't walk into KNA. But if they do,
I got that.
yeah. So that's our
We
newest.
don't, can I say we don't always have a pediatrician at KNA?
Yeah.
Just so you know.
We absolutely do not have a NICU. And then, so that's our substance use disorder treatment, and I guess we have partnerships as well with some churches that do like recovery and Bible studies in our lobby. And then the other thing we have at KNA is that the Orange Hub is our rapid response team, so whoever's working in that hub, even if they're a pediatrician, if our security who rolls the block sees, or really anybody, but mainly it's our security, if they find someone who's overdosed, they will have a walkie that's just for this, and they walkie us down, and we respond to overdose on the street around.
Do the other sites have teams? I thought that
I
they did
don't-
if necessary, but.
I mean, so within the clinic, we have our code blue, which is everybody goes. And so this one, not, for that walkie, just when there's overdose outside, not everybody goes.
But
just
does
the Orange
Hunting Park have a rapid response?
Not that I'm aware of.
Huh, I thought they did.
Maybe they do now.
They really don't need it necessarily. I know, Fifth Street had a whole
Fifth Street has
load
yeah.
of people.
They only have 2 providers, so.
So it's, yeah, so they don't, yeah, just run it in, you know,
Yeah, exactly.
Yeah.
Yeah,
Somebody
we all
will-
stock Narcan, and we
somebody-
all stock.
oh, okay.
Yeah, so
Yeah,
we
no.
all have our
So-
rash
so-
cards in the clinic, and we also have rapid response bags, which are primarily Narcan and ambu bags.
So just so you know, Esther Lee, who you met yesterday, gave Narcan 7 times one day, about a month, 6 weeks ago. So, yeah. Yeah. I think, like, on the sidewalk.
Yeah, it was constant for a while
It was scary.
that we were responding, and well, it is still fairly constant, so, and that's why we, at KNA, and that's why we,
Have a specialty.
yeah.
Separate.
Yeah. We do medication-assisted treatment for opioid use disorders. We hear this called MAT or MOOD. We used to call ours MAT because we're really easy to have a switch. But, and that is another one that can be controversial for Christians because it can feel like you're replacing an addictive drug with an addictive drug, and that is what you're doing. But what you do, or the point of it is well, there's a couple points to it, but the main point for us is that the medication gives the person the space to do the work of recovery. So we very frequently say that therapy is the therapy, and the Suboxone just gives you the space to do the therapy. So you replace the opiate, so in our case fentanyl that they're using on the street, with, in our case, buprenorphine, if we were a different type of site, methadone. And because they don't have to do all the work of getting that drug, which usually is commercial sex work or criminal activity, or just the attention is no longer on meeting that craving, they actually have time to consider the other aspects of their life, and they're a little more stable. And then the goal is eventually to take them off. Some people will never be able to come off completely, and that's okay. And some people, usually within 2 years, they're starting to taper down their dose. So methadone, highly controlled by the government in the United States, and it's only dosed at about 8 sites around Philly. It might be a little more now. And prescribed by addiction specialists. When I started working in addiction, a high dose of methadone was 60 milligrams, and now I regularly have patients who are on 120 or 140 milligrams, and that's because of fentanyl. It's synthetic, but it's basically heroin. There's not a lot that's different. In Canada, they use medical grade heroin. It's a safer supply. You're less likely to overdose. And it doesn't have all these things in it. We use buprenorphine, which is the weirdest drug in the world. It's a partial agonist, so it preferentially knocks the opiate off of the opiate receptor in the brain, the opioid receptors. And what that means, but it doesn't have the CNS depressive effect, so it doesn't decrease their respiration or sedate them quite as much as other opioids. And it has a ceiling effect for those things, so you can give someone a very high amount of buprenorphine and it won't decrease their respiration like if you give them a high amount of methadone. So I think you'll see it more and more used for hospital analgesia treatment because it's the safety profile. Right now, it's only approved for addiction treatment in the United States. The problem with buprenorphine is that you have to come completely off of the opiate in order to start it, because if you use it, because of that preferential knocking, the preferential fitting on that receptor but not completely stimulating it, it kicks them into withdrawal if they have any opiates in their system. And that's a particular problem with fentanyl because of that lipophilic thing where it can stay in your system for like 2 weeks. So which means that they're going to feel a low level of fluishness, high level, for quite a long time. And for folks who are used to being on heroin, they think like, well, I'm just going to wait 24 hours and then I can start with buprenorphine because that's how that works. But with fentanyl, then they start the buprenorphine and they can't work out why it's not working and why they feel more sick.
Wait, so then for fentanyl users, would you just taper them off like 2 weeks before starting the buprenorphine?
Yeah, but nobody is able to taper.
Yeah.
So in an
Yeah,
ideal
so-
world, yeah, but almost nobody can do that, right? Because then we would just keep them off of it forever.
Yeah.
So we have a couple ways. So one, we're still working this out. So most of the conversations that I have with other programs in the city and around the nation are like, how do you guys induct? How do you guys induct? Because the place where we lose most patients is during that induction phase, getting them off of the opiate onto the buprenorphine. If we can get them onto the buprenorphine, then we're good. We can work with everything else, but getting them on is really difficult. So there's a couple ways to do that. One is you give them, you tell them wait as long as you possibly can. We give them the COWS score, which is a scoring system for like, you need to be more sick than you've ever been, and then wait 45 minutes, and then try a sliver of it if it makes, and then there's two ways to do it. One, take a very low dose of bup while you're using fentanyl and kind of creep up on it. It's weird that that works, but that works. And then the other way is to actually try to overcome the fentanyl with buprenorphine. So we give them extra buprenorphine so they go into withdrawal when they take the first buprenorphine. Instead of using more fentanyl at that point, use more buprenorphine and try to overcome the withdrawal. But yeah, so basically you're just gonna.
And would you ever mix treatment with methadone and buprenorphine?
No, because they'll antagonize each other. Yeah. Methadone is much harder to access wise, but you can go straight onto methadone. People don't like the side effects of methadone. They don't feel good on it. So most of the folks that we talk to, so when they come in, we'll say to them, here's how we get you onto it. If it doesn't work, come back. That's our number one priority. If this doesn't work, come back. We will try other things. We give them every adjunct medication that you can think of. Like, this is definitely a throw the kitchen sink at them.
Okay.
So we give them clonidine. I would give them a benzo. I very frequently don't do that, but we give them anything that we think will work with so some muscle relaxants, because they're going to feel achy and fluish. Actually makes Suboxone stronger. We actually want that in this case. Suboxone's CYP3 and 4 metabolic pathway. So it interacts with every medication that we all take, and people have weird genetic variations in how they metabolize it, so that messes us up too. But so gabapentin, cyclobenzaprine, they're drugs that actually make Suboxone stronger, and we actually want that in this case. So we'll specifically prescribe those drugs to help them get through that initial phase, along with ibuprofen and acetaminophen and old medications, nausea medications, sleeping medications. Buprenorphine comes most commonly in films. It also comes in tablets, and then it also comes in injectable forms. And the nice thing with the injectable forms, so we're using that a little bit more. You have to be completely off of opiates to be on the injectable. So usually we do a trial of the sublingual films before we'll give you the injection. Although we're starting to see some evidence come out that maybe we don't need to do that, and we can just manage. It is the nice thing about it, because buprenorphine is also lipophilic, so it builds up in your body over time, so when we give them subsequent injections of buprenorphine, which is every 4 weeks sub-Q injection, it's very available. It actually has a cumulative effect, so we can get higher levels higher serum levels of the buprenorphine in your bloodstream, which eventually, and it's usually, everybody's different because of how we all metabolize things differently, but it's usually after 2 or 3 injections it will actually blockade fentanyl. So if they, famously we had a patient who, she was on injection number 3 of the Sublocade, the injectable form of buprenorphine, and using films on top of that because that injection is not strong enough to match fentanyl. And she and her mother, who also struggles with addiction, bought some Percocet off the street and used it. The Percocet was really fentanyl. The mother overdosed and our patient was, her Suboxone blockaded it and she didn't feel any effect at all. Her mom lived, but didn't go to the hospital. So that's an advantage, because if you're an addict and you're thinking about using, and you can't because we've given you an injection, so just knowing that you can't use in your most desperate, I'm having a bad day and I feel like using, but if I use, it's gonna block anyway, so I can't use, that's massive. That gives someone the ability to get to the next day. Yeah.
When would you use like methadone versus other medications, or is it like this thing of what you can one and next one, or is it just kind of like trial and error?
Usually it's patient preference, so methadone will work better for fentanyl. So in an ideal world, everybody would be on methadone. In reality, in Philly, methadone is hard to get to. It's barrier to care. There's high barriers to care. Some people have had bad experiences of it, so they want to go. You have to go daily to get your dose, and the dealers know that, and so all the benzo dealers hang outside the methadone clinics, and the meth dealers and the PCP do. So some people don't want to deal with that. Like, they know that they will use other things if they go on to methadone. I worked in Australia in addiction, and there methadone is dosed in a local pharmacy. So I would go into my pharmacy in the morning, and there'd be a line of folks who were there to get their methadone. Much lower or much easier access, much lower barriers to care, and if we had that, I would use it.
Is
We
the,
need to keep
Okay, go ahead.
okay, is the buprenorphine, like, is it better long-term, or does methadone, like, block fentanyl, like, use to, like, not use?
Methadone does not block, so you can theoretically use heroin, and in the old days, we would be like, we're gonna put you on methadone and force march you off in 6 weeks. And that turned out to be a really bad idea, because people just use heroin on top of it. So with the methadone, because it is an opiate, it's not, doesn't have an antagonistic effect. They used to say it's preferential on the receptors, and I think we realized that that's not in fact the case. So you can use heroin or fentanyl on top of methadone. So if you underdose the methadone, they're going to use on top of it. And I think that's what the realization we all had to come to is that, 160 milligrams of methadone is a massive amount. That's going to cause prolonged QT. It's going to, that is a massive amount. And the crazy thing is to see people, like, when I'm looking at their chart and they're on that high a dose, I think, how are you conscious? I know that you must have gotten this within the last couple hours. So so it's a very, if you keep the level high enough, then hopefully they won't relapse on something more dangerous. But methadone won't blockade like that. So, and then naltrexone, you'll hear also a lot of Christians will get really into giving people naltrexone, which is an antagonist. So if you take naltrexone, then that's what we use to reverse opioids, right? So it pops off the opioid. It doesn't. So it's marketed as something called Vivitrol for opioid use disorder and alcohol use disorder. It also comes in Australia. We were using an implant for that. The problem with it are two things. One is it's no match for fentanyl. So if they use fentanyl, they're going to overcome the Vivitrol in the doses that we're allowed to prescribe. Columbia University tried to use Vivitrol to block fentanyl, and they needed to dose 3 or 4 times the amount that Patron let us dose. So it should work, but not in the way that we're allowed to prescribe it right now. And then the other thing is that people will substitute. So when there was a heroin drought, when we invaded Afghanistan and San Francisco, people immediately, the whole street switched to methamphetamines, which is almost worse. Because it's more violent and it causes more, it's harder to get off of. So naltrexone we don't use, and I have an alcoholic on it, but in general we don't use the Vivitrol or naltrexone, not because we don't want to, just it's not adequate in the face of fentanyl. And, okay, so response responding to overdose. So you guys almost certainly this summer will come across someone who's overdosed. We respond to probably 3 or 5 a month at K&A. And so the big trick is it's straightforward. This is our current form. This is what you guys have, right?
Yeah, they're gonna get some training when you're finished, yeah.
We're gonna get more training?
Yeah.
Okay, yeah. So the hardest part about responding to overdose is figuring out if someone is overdosing. Naloxone, which we call Narcan, is the antagonist. It kicks the opioid off rapidly and it reverses it. It's there's a lot of it's about to come out generic and in a higher dose than it currently comes out in 2 milligrams about to come out.
The times we've had to use it, one time we had to use it 3 times.
So in the old days, we would say if you've used it 4 times and you haven't gotten a response, you're not dealing with an opioid overdose. That is no longer the case with fentanyl. You just keep going with that because you can almost guess, even if they overdosed on benzos, there's probably fentanyl on board, and maybe you can reverse that overdose if you keep going with it. So so much higher doses than that. They're going to start providing it in higher doses, like in a minute, and per pH. We'll go back to the next one. So the hardest part is to figure out if someone's overdosing or if they're just nodding. So usually what I do when I'm someone that looks like they're not moving is I speak to them first, then I hit their shoulder, and you gotta be aware of the needles around you, and then do a sternal rub. Also, if you just say the words Narcan, sometimes they'll wake up. They don't want to be Narcan.
Yeah, if they're really
So
high,
sometimes you'll get a
they do not
response.
want you to give them Narcan. Yeah.
But I mean, what you're looking for is someone who's not breathing, and not breathing is less than 8 breaths a minute. Go ahead.
If you gave someone Narcan that wasn't overdosing, what would happen?
Nothing.
Nothing.
So you cannot do someone harm
Okay.
with Narcan. So when in doubt, give Narcan. It definitely is. We once had a diabetic who was hypoglycemic go down outside of our clinic, and he did not give Narcan. Other people did before. He was like, "No, I'm diabetic." But no harm done. Give the Narcan. That's because a lot of times, even if people around you are like, they didn't use fentanyl, they don't know what they used, they may have thought they used something else, and it ended up to be fentanyl, like marijuana. So they're not responsive to noxious stimulation, like you yelling, "I'm going to give you Narcan," that word, the sternal rub. They're gray, clammy, and they might breathe this agonal breath. So you look at them and you go, this person is
Struggling.
Yeah. An agonal breath is where it's not a useful breath, so they'll go like that, and you think, oh, they're breathing, but they aren't. They're not breathing rapidly enough. So usually we check pulse. You guys are doing CPR.
Mm-hmm. Well, we're going over kind of how to approach, and then bystander CPR, and then we do have face shields if there's people doing it.
Okay, great. Yeah. Check pulse, carotid, not there, because if they're using opioids, you might not be able to get the peripheral pulse. So check a carotid pulse and do CPR if you're trained to do CPR. But give the Narcan, that's the number one thing. So one nostril, 2 minutes later in the other nostril, and that
2
is
minutes,
it.
huh?
The longest 2 minutes of
I know,
your
but
life.
can I say the last time I was trained, they said wait 3 to 4. Because
Yeah.
they thought
just say
it was
together.
normal.
I feel like it's the longest 2 minutes here, and then I think and then rescue rating is most often what's needed. The xylazine, and here's the 2 Philadelphia things. They might not regain consciousness even though they start breathing again. So they might start breathing normal respirations, 8 and above. So we stop bagging when they get to 8 respirations and up. Because we have bags. But now, because of that xylazine, which is the clonidine twin, they actually frequently don't regain consciousness before the ambulance gets there. They do eventually, but they'll start breathing. You see their color come back and they start breathing normally, and their pulse is nice and strong, and then you're like, why is this person still not responding? And that's the xylazine that's mixed with the heroin. So if that happens, it doesn't mean you need to give more Narcan if they're breathing. Okay. And then the other thing in Philly is that bystanders do the craziest things, including the policemen sometimes. We had a policeman who stepped in between me and Tim Lehman, and to the point where I was like, I just need you to step away from like the doctor who's trying to give this person CPR. So they will just do weird things. And sometimes because they're high themselves, and sometimes because they just I don't know why. So frequently, if you are responding to someone, it's good to have someone who's who can just field that, like, hey, can you step away while they do this? If you're not someone who's going to do CPR with them, and yeah. So yeah, it's just a weird thing that happens. People respond. Awesome. So this is another quote from Gerald May from Addiction and Grace, which for 25 years I've been calling Grace and Addiction. Just leave you to read it. I think when I talk to our providers about their experiences of working in that, because there's a lot of hesitancy to take this on when we kind of first started it at Esperanza, and now I have more providers than I have mat sessions. They all want to do it, and I think it's because you really see people at their most vulnerable as humans, and at their most, something about addiction cuts to the core of who we are as children of God, and to see see their humanity restored and see them step back into that long process of moving towards the light and away from the darkness is really a privilege. All of us in our careers, I mean, we think about the pandemic as a career-defining event, but I think actually opioid addiction is going to touch all of our careers no matter what field you end up working in. And so I commend it to you as those are not the patients to avoid, but the patients to embrace, and because it really is crazy rewarding when you see kind of their lives kind of come back into restoration. You see them make those connections and take those steps and move forward. And for me, it helps me in recognizing where God's working in our world. It also helps me recognize how God works in me and when I have to face my shame and addictions, and in watching them kind of journey with theirs. So tear up the roof and find doorways for grace. Okay, so we're going to end. Any questions?
Just one question. So let's say like a patient is interested in more faith-based substance use treatment, or maybe they're just talking about faith and also they're trying to get clean, and say they're like on Medicaid, are they able to like get into Esperanza's like final studies and things like that, or is that?
Yeah, so we do faith-based. Our groups are focused on relapse prevention, so the very early stages of addiction. And then usually we'll do, and people can opt for a group or individual, and we do, both are faith-based. And, but I mean, we also, like, we have people who do not identify as having a faith, and we also have like Muslims who like to come to us because they feel like they can talk about God in our space safely, and yeah. So but yeah, it is a faith-based recovery program.